Hello and welcome to Health Professional Radio. I'm your host, Neil Howard. Thank you so much for joining us for another segment. In this segment, we're going to be speaking with Dr. Matthew Weir. He's attending physician and director of the Division of Nephrology in the Department of Medicine at the University of Maryland Hospital. He's joining us on the program this morning to discuss the large ADMIRAL trial. Welcome to Health Professional Radio. Dr. Weir, thank you for joining.
Well, thank you so much. It's a great pleasure to be here.
I did mention, of course, your role at the University of Maryland Hospital. Give us a brief look into your professional background, and then let's talk about this ADMIRAL trial.
Sure. I did my medical school at the University of Virginia in Charlottesville, and then internal medicine residency training in the Yale system in Connecticut, and then my fellowship training in kidney diseases and transplantation in the Harvard system in Boston. Then I moved to the University of Maryland, 1983. I've been here ever since, very involved in many aspects of kidney disease, most important of which is kidney transplantation, which has always been a very important interest of mine.
Who qualifies for a transplant? When is function compromised enough to require a transplant?
Well, kidney transplantation by far and away is the preferred route to go for somebody whose kidneys are failing. It is much preferred over dialysis, in large part because you live longer and you feel better. Dialysis is certainly an adequate strategy for renal replacement therapy, but it is not the preferred one, in large part because it is indeed artificial. It takes skill, time, and effort, but it is life-saving. But the beauty of a kidney transplant is, in large part, better for your circulation, reduced risk of cardiovascular disease progression, and you have a life ahead of you. You live longer and you actually feel better with better clearance of the breakdown products of your diet in the bloodstream. And that's really one of the key problems with chronic kidney disease, is that you don't feel well or as well as you should, simply because artificial measures for cleaning the blood are not as good as actual kidney function itself.
Are there instances when a person is just not a candidate for transplant, not because of availability, but they simply, dialysis is the only way for them to go?
Yes. I mean, the whole strategy for providing good quality chronic kidney care is to identify people who are likely to progress and require a transplant. And this requires some foresight and some planning and some education to identify potential donors and friends who could step forward, as well as to utilize social media. Certainly, we want to be able to transplant people before they require end-stage renal disease. Again, in order to do that, we need donors. To qualify, you just need to demonstrate that you're otherwise reasonably healthy. We do screening tests to make sure there are no occult heart disease or heart disease or cancer, things like that. You have to demonstrate some degree of compliance. And also, two, you have to be in reasonably good shape to undergo an elective surgical procedure. But we're very careful about that. But planning ahead is the key.
The ADMIRAL study, what was the study investigating?
Well, first of all, with any clinical trial, you have to understand the definition of the acronym which describes the study. ADMIRAL actually stands for Assessing AlloSure, Donor-Derived Cell-Free DNA Monitoring Insights of Renal Allografts with Longitudinal Surveillance. I know that's a mouthful, but that's what ADMIRAL stands for.
Well, I'll just use ADMIRAL.
This is that's what ADMIRAL means. So this is a large study. It involves more than 1,000 patients from 7 different kidney transplant centers who are monitored in a real-world setting for approximately 3 years. And basically, we used this newer cell-free DNA technology for surveillance But the name of it is donor-derived cell-free DNA, and its trade name is AlloSure, as part of our standard of care to see whether or not this would provide some advantages in surveilling the patients in terms of, again, identifying any early signs of kidney damage, kidney rejection, and to see whether or not it would impact long-term function.
So what were some of the findings of this study?
Well, let me give a little bit of background. Historically, we've been doing kidney transplants now since 1954. And actually, the center where I trained, the Brigham and Women's Hospital, performed the very first successful kidney transplant in a human, which is really quite exciting because while I was there, I was able to meet some of the people that were involved in that early transplant. But the bottom line is for many, many decades, we've been using a crude measure, that is the change in serum creatinine, as a measure that the kidney may not be functioning well. Unfortunately, this measure is not as sensitive as we would like. And because of that, kidney damage can occur in a subclinical or unidentified way, which could obviously impact the longevity of the kidney. Mm-hmm. And so obviously there is an unmet need for developing new technology, which is far more specific, far more sensitive than a serum creatinine to identify injury in the kidney, particularly as it may be occurring subclinically. That is, before it is identifiable with traditional laboratory measures, such as the serum creatinine. And so the ADMIRAL study was one of several studies that have been conducted in the last few years to expand our understanding in this regard, to facilitate our ability to identify subclinical injury of the kidney, and particularly rejection, as well as to use predictive modeling to see whether or not this would impact long-term kidney function. One of the long-term concerns about kidney transplantation is the development of donor-specific antibodies by the immune system of the recipient. We know that the development of donor-specific antibodies portends the development of chronic antibody-mediated rejection. And this clearly is one of the factors that shortens graft half-life. Every kidney we would prefer should serve their owner for their remaining life expectancy. And once you start developing donor-specific antibodies, that's a grave concern that will not be the case and could lead to progressive graft loss. Mm-hmm. And the patient then having to re-enter the waiting list again for another kidney. The beauty of our results from the ADMIRAL study is that it is a much more sensitive and early predictor of de novo donor-specific antibodies. This was really an impressive observation. Not only that, it was also very helpful in identifying earlier the development of subclinical graft injury and rejection. And we were able to develop sensitivities and threshold levels for raising concern with that. And that's really the most important observation. That is, this is a much more sensitive and earlier identifier of graft injury. And we even noticed that with this sensitive methodology, with our 3 years of follow-up and more than 1,000 patients, that it was capable of identifying people who were more likely to sustain a reduction in kidney function over time. So this is really a big step up and obviously a very important scientific observation to facilitate strategies to improve graft longevity and to reduce the likelihood of graft loss over time. The study was very recently published in Kidney International, which is a very prominent kidney journal. It could certainly be looked up there. I don't have the actual citation with me right now as it is in press. But going to PubMed, certainly one could look up the ADMIRAL study as published in Kidney International in its preprint form.
And I do believe that Kidney International has a website, kidney-international.org. Is that correct?
I believe so.
Yes,
I couldn't tell you, but I always go to PubMed or Google, which is the paragon of medical information to provide that type of information.
Absolutely. Well, I appreciate you joining us here. Hopefully we'll have you back and discuss some more.
Absolutely. It's a very great pleasure to be here. I just like to remind the audience that, believe it or not, kidney transplant failure is the fourth leading cause of end-stage renal disease in the United States. And so really anything we can do to reduce that is going to be a great advantage for us, given the scarcity of kidney organs for transplantation. Thank you. I appreciate the opportunity.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Matthew Weir. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download it, SoundCloud, and be sure to subscribe to our YouTube channel at youtube.com, Health Professional Radio.